Hello everybody, this is Dr. Padel. Welcome to first part of arterial blood gas analysis and acid-base disorders. So let's start with the disclaimer. This video is intended solely for the education purpose of fourth year medical student. This should not be used as a direct source of reference for making clinical medical decisions. Learning objective for today include briefly discussing about arterial blood gas procedure. Then we'll be talking about indication of ABG analysis. Do we really need one, or venous blood gas is good enough? Then we'll be discussing about a general framework for the approach to patient with possible acid-base disorder. And then we'll be briefly talking about respiratory chain and its implication in oxygenation and ventilation. Some of it will be completed in part 2 as well. Let's dive into it. So let's talk about ABG procedure. Like in all procedure, you'd like to first obtain a consent. After explaining reason for the procedure, talking about alternatives, talking about risk and benefits. And you would like to do Allen test. So the reason to do Allen test, as you can see in this picture, so radial and ulnar artery, it is connected through this arch. We call it superficial and deep arch. So in some people, there is no connection between these two arches. So what happens in that case? In that case, radial artery and ulnar artery becomes the end artery, and there will be a risk when you puncture end artery. So that's the reason why you would like to do Allen test. So we'll be talking about Allen test in the next slide. So site selection, radial versus others. So typically we use radial as a side, and very rarely we also use femoral. So in terms of steps, step 1, you would like to prep the area, you'd like to clean, then you palpate the area, and then you trap the artery between two fingers placed on either side so that it does not move. Then you hold the syringe like a pencil and enter the skin at 60 to 90 degree. Then you obtain blood on downstroke or on slow withdrawal. So remember, artery is a high pressure system. As soon as you enter the artery, the needle starts filling with the blood. And if you are not able, withdraw the needle and you redirect. After obtaining the sample, you have to withdraw the needle quickly, then apply firm pressure for at least 5 minutes, and then you document the procedure. So let's talk about Allen test. First, you are going to ask your patient to make a tight fist. Then you are going to use your thumb to occlude both radial and ulnar artery. You are going to ask your patient to squeeze and release hand repeatedly so that their hand blanches faster. Remember, this test should be done with the hand partially open. Otherwise, if you have your patient hyperextend their hand, it will result in false negative. So once the hand blanches, you're going to release the pressure on one side, and typically it is the ulnar side. And you maintain the compression on the radial artery, and you're going to note how long it is going to take for each finger to regain the pink color. So that duration you're going to measure, and you're going to repeat the test on the other side. So that's how you do tests, and that timing is important. As you can see here, different rule, 3 second versus 6 second. 3 second has a high sensitivity, but specificity is very, very low. So we go by rule of 6 second, where sensitivity is reasonable and specificity goes above 90%. So in 6 second, If hand floss is red, then we call it positive modified Allen test. That means you can perform the blood draw. But if um, there is no flossing, if there is a delayed flossing, that is after 6 seconds, then that is called negative modified Allen test. Means there is no robust connection between those two um, arches, and you should not be performing blood draw. After the draw, you would like to expel any air from the syringe. Then you'd like to mix the content thoroughly. Um, then we have to make sure that the syringe is airtight with the cap and it is transported on ice. Low temperature decreases the metabolism and decreases the oxygen consumption. Then the goal is to analyze as quickly as possible. Otherwise, oxygen will be consumed by the WBC. This phenomenon called leukocyte fluorescency is very commonly seen in people with leukemia, where um, high WBC count actually contributes to consumption of that oxygen, and then their oxygen level on ABG is falsely low. The source of error could be from delay in the transport, because if you make a delay, you know, oxygen is going to be consumed by WBC. So the effect would be minimal if, as long as you do that analysis within 15 minutes and you are transporting with ice. Sometimes acidic heparin is used. It can affect the pH of the sample, but the effect would be minimal if you have at least 2 milliliter of the blood sample. And also you'd like to get rid of the air bubbles that is trapped in the sample, and that will actually result in, if you don't remove those bubbles, those bubbles contain oxygen and can result in falsely high PaO2 of the sample. So let's talk about, do you really need ABZ? The answer is no. Central venous pH, PCO2 and bicarbonate, they have a reasonable correlation with arterial pH, PCO2, except in the patient with a severe circulatory failure. So central venous pH is 0.03 unit lower than arterial pH. PCO2 is 5 millimeter of mercury higher than arterial PCO2. Bicarbonate, lactate and base deficit are almost equal to arterial bicarbonate. So for that reason, we don't really need ABZ, unless you want to know about the oxygenation status, because BBG does not provide patient oxygenation status. But pulse ox can provide oxygenation status. So as long as pulse ox is providing that oxygenation status, why do you really need ABG, which is invasive? Sometimes that pulse ox is not reliable. So those are the people with shock. And what about EtCO2 with arterial PCO2? So it works as the procedural sedation. So who still needs ABG then? So those are the people who are grossly hypoxic, somebody who is an ARDS, or somebody with a poor circulation with or without shock, which limits the use of pulse oximetry. Then there are two subset of population: post-cardiac arrest people and neurotrauma patient, where you would like to do permissive hypercapnia, where precise measurement of CO2 is critical. So those are the people where you want to do ABZ. In ARDS and shock, you can start with ABZ and then you correlate with the end-tidal CO2 and oxygenation with pulse ox once circulation or pulse ox measurement improves. So in this severe disorder, at least you get one ABZ. So we are going away from doing ABZ in every um, person, especially when you want to know about carbon dioxide. Venous gas has very good correlation with arterial, so we don't really need to do ABG in all people. So let's discuss about a case. AA is a 64 male admitted with progressive shortness of breath, has a long-standing history of COPD and is on home oxygen therapy. While in hospital, he develops an episode of worsening shortness of breath and RRT was called. He has had ABG done and you're called and asked to review the patient and the ABGs. So what are you expecting to see on the ABG? So this is the blood gas you got. Patient has a pH of 7.27, PCO2 of 28, PO2 of 52, bicarbonate 14. Remember, bicarbonate in ABZ is um, the calculated one, is not the measured one. So you are not going to use this. And then oxygen saturation of 92%. So what is the underlying acid-base process? So as you see, pH 7.27, which is acidosis. And then acidosis with low carbon dioxide. So carbon dioxide is not contributing, so it's most likely metabolic in nature. If it is metabolic acidosis, so the next step is to calculate anion gap. So for that reason, you need to have a BMP ordered on this patient, and most likely we might be dealing with infection, pneumonia, sepsis versus lactic acidosis versus other cause of anion gap acidosis. That's what you are going to look for, because these are the differentials in this patient. When should I suspect acid-base disorder? Somebody with a unexplained shortness of breath, marked change in fluid or volume status, abnormal bicarbonate. Remember, bicarbonate in ABZ is not the measured one, it's a calculated one, so you are not going to rely on bicarbonate in ABZ. And then the last but not the least, increase anion gap. If somebody has anion gap, even at the normal pH, there is some process going on, and usually they have a underlying acid-base disorder. What do you actually learn from ABZ? So let's discuss about some definitions. pH is defined as a negative logarithm of hydrogen ion concentration. Um, so normal hydrogen ion concentration is around 40, and that results in pH of 7.40. So acidemia is pH less than 7.36, alkalemia pH more than 7.44, normal pH is from 7.36 to 7.44, normal PCO2 40, normal bicarbonate 24. So as you can see here, negative logarithm of hydrogen ion concentration, which is so 40 nanomole. So when you do this math, that results in pH of 7.40. So what happens when hydrogen ion doubles? So hydrogen ion doubles when, let's say, hydrogen ion is 80. So in that case, so the pH is going to go down to 7.10. So hydrogen ion is dependent on the ratio of PCO2 and bicarbonate, which we're going to talk in next slide. So if PCO2 doubles while bicarbonate remains constant, pH will drop by 0.3. Um, so remember, mixed disorder of acidosis and alkalosis may be present even if patient is neither acidemic or alkalemic because of compensation and everything. So let's talk about Henderson-Hasselbalch equation. So pH is equal to pK plus log of base by acid. pK is a dissociation constant, which is 6.1. So the rest is log of base, which is bicarbonate, divided by acid, which is carbonic acid. So remember, bicarbonate normal is 24, and that carbonic acid is 1.2. So the ratio of 20:1 is maintained, and log of 20 is equal to 1.3, is going to be total of 7.4. So that's how we calculate normal pH. So let's say bicarbonate is 48. So there is a doubling of bicarbonate. And then the carbon dioxide normally is 40. So let's say carbon dioxide again went to 80. So let's say. So in that case, patient is going to have a normal pH. Why? That ratio is maintained. The ratio of bicarbonate by acid is maintained. And similarly, let's say bicarbonate is reduced to let's say 12, and then let's say the acid, which is carbon dioxide, is also reduced by half. Let's say the pH will be maintained. Because that ratio of 20 is to 1 is still maintained, and log of 20 is 1.3, which results in normal pH. Let's talk about PCO2, partial pressure of carbon dioxide. So remember, carbon dioxide is very much permeable. In fact, respiratory membrane is very much permeable to carbon dioxide, more so than oxygen. So whenever you have increase in carbon dioxide, the likely etiology is not related to something defect in the membrane, but the defect is in the ventilation. So the normal is 4D. What about the venous sample and PCO2? So, there is a correlation that we already talked about. So, based upon these different studies, the correlation is around, around 5 to 6 millimeter higher number of PCO2 you can actually you get in venous blood sample. And there was a study where they found the study by Kelly et al. Published in Journal of Emergency Medicine 2005. What they found was, PCO2 less than 45 has 100% negative predictive value for hypercarbia. And this is something you can actually utilize in a clinical practice and avoid artificial arterial puncture in your patient. PO2 is partial pressure of oxygen. It's a measure of oxygenation only. So let's talk about bicarbonate. Bicarbonate in ABG is always calculated from pH and PCO2 using Henderson-Hasselbalch equation. So therefore, we have to use bicarbonate that is in BMP, which is more accurate. Normal bicarbonate is 24. So whatever CO2 number that you get in BMP is what you are going to use. So total number of all CO2 present in blood is 24 to 31, and it includes three different number. It includes carbonic acid, it includes bicarbonate, and it includes carbamino compound. So that carbonic acid and carbamino compound are very negligible. That CO2 essentially reflects that bicarbonate compartment. So that's why when you are doing any math, you are supposed to take CO2 number from BMP for calculation purpose. Or an oxygen saturation useful in determining acuity and severity of individuals' hypoxemia. So base access is kind of obsolete number that many people they don't really use it. But it gives you a little bit information, gross information. So base access, as the name suggests, so there is an excessive base. So patient has a metabolic alkalosis when base access is more than 3 plus, or they have metabolic acidosis if they have a base access less than -3. So the role of pH in plasma potassium level. So acidemia results in high potassium number. So whenever there is increased acid, acid tends to go inside the cell. When acid goes inside the cell, something positive needs to come out of the cell, and which happens to be potassium. So acidemia results in high potassium. On the other hand, alkalemia results in low potassium from the same mechanism. So pH change of 0.1 results in 0.5 change in potassium. So that's about rough math in terms of calculation. So like we talked about, whenever hydrogen ion goes inside the cell, potassium needs to come out. That results in higher potassium number. So serum potassium is more than plasma potassium. prolonged acidosis results in renal potassium wasting. Whenever you are writing ABZ, you are going to follow this convention of writing. You start with the pH, followed by CO2, then oxygen, then bicarbonate and oxygen saturation. So let's discuss about anion gap. How does this gap exist? All the compartments are supposed to be electrically neutral. So there is no electrical gap. So the gap is between on-major anion and on-major cation. So there are 23 total on-major anion, and then there are 11 on-major cation. So that gap is between those on-major anion and cation, and the way you find that out is by subtracting the product of chloride and bicarbonate from sodium. So that is going to give you anion. Remember, normal anion gap is 12 when you are doing any math. So steps to interpreted ABZ. So first of all, you identify the primary process, whether it's acidosis or alkalosis. Then, once you determine that, you need to find out whether it's, respiratory or metabolic, which is the primary disorder. If somebody has acidosis with low carbon dioxide, means it's probably metabolic. If somebody has acidosis with high carbon dioxide, most likely respiratory acidosis. So there you tend to find out the primary pathology, and then you calculate anion gap. So anion gap is calculated by subtracting the product of bicarbonate and chloride from sodium, and then the normal number for anion gap that we already talked about is 12. If somebody has a low albumin, you're supposed to correct 1 gram drop of albumin from 4, you add 3 to that number, to that anion gap number. So if somebody has albumin of 3, that is 1 gram drop, that is, you have to going to add 3 to the calculated number. If somebody has albumin of 2, normal albumin is 4, so 2 gram drop, so you add 3 and 3, you add 6 to that anion gap. Then you calculate delta gap. How do you calculate delta gap? So that measured anion gap, and then what is the normal anion gap? That's 12. So that is the delta. Then with that delta in the system, that is actually going to occupy the compartment that is being occupied by bicarbonate, right? So the expected bicarbonate with that degree of acidosis is going to be 24 minus delta gap. So, and then you calculate that number, and then you look whether that number corresponds with patient bicarbonate number. If your patient has more bicarbonate than expected, that means patient has additional metabolic disorder, which is metabolic alkalosis. And if your patient has less bicarbonate than expected, patient has metabolic acidosis. Then you go to respiratory compensation. So how do you calculate respiratory compensation? Winter's formula, expected carbon dioxide. So expected carbon dioxide formula is bicarbonate into 1.5 plus 8 plus minus 2. So you calculate that number, and then you look at the number from ABZ. So if the ABG carbon dioxide is higher than what you calculated, then that means patient has a respiratory acidosis. If patient carbon dioxide is less than what you calculate, it's a respiratory alkalosis. And then you try to fit those, combination of metabolic and respiratory disorder, and try to paint a picture with those 3 information that you just got, and you come to the diagnosis. So this concludes the first part of acid-base disorder. Our second part is going to be about respiratory acidosis, alkalosis, metabolic acidosis, and alkalosis, and indication of oxygen. Thanks for watching.